Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the areas of advanced illnesses, specifically those that would qualify for either palliative care or hospice care. Those are two separate types of services. I'm also a certified end-of-life doula through the International Doula Life Movement. I am an avid writer, having published well over 500 healthcare articles, an avid book author and publisher, having published 21 books for hospice nurses, 24 for caregivers, 5 for holistic nurses, 6 for my fellow end-of-life doulas, and I'm currently working on a book in a brand new series looking at the healing process of grief and loss through the lens of the Bible from a Christian perspective, that healing is really integrating that grief and loss into our walk with Christ Jesus. If you're new to this channel, welcome. Thank you so much for taking the time to visit. In this channel, we talk about issues related to death and dying and the journey along the way. After all, we are all going to die. If these are topics of interest to you, please consider subscribing and hitting the bell notification below. I try to publish videos every Monday, Wednesday, and Friday. Sometimes there might be a little less, sometimes there might be extra ones, along with an occasional gardening or house project update video. And if you like the different topics, it does help get the message out to others who may have similar interests as you. The topic for today's video is going to be for my fellow hospice nurses. For those following this channel, I do videos sometimes for my hospice nurses, sometimes holistic, sometimes for patients and caregivers, for doulas and other end-of-life professionals. For today, again, my fellow hospice nurses, this is in response to one of the medical directors that follows me from time to time. Will reach out for advice. How do we help their staff, their team, to handle something differently? It might be a time management perspective. It might be, in this case, admission recertification perspective. Before we go on to the topic for today's video, I want to ask you a question. What are you grateful for? What are you grateful for? I find that in my walk in life, and those that I talk to and communicate with throughout our lives, we have loss, we have grief. We sometimes things are traumatic, but not always. Sometimes it's those micro losses that beat up against us and eventually build up towards like the straw that broke the camel's back. How do you get through all of that? In my experience, it's by building resilience is one of the answers. It's not the only answer, it's one of the answers. To me, there are 3 pillars. If you wonder what the other 2 are, because one's gratitude, comment and ask below. This is a non-judgmental channel. What am I grateful for? I am grateful for you for being here. Even if you don't comment and I don't know your name, even if you're in and out, you at least stop by even for seconds. I am beyond grateful for everyone who buys and reads my books. Thank you so much. That helps me tremendously. I operate Compassion Crossing LLC. It is an RN concierge and doula service. I do a lot of like with living wills, powers of attorney, illness navigation, public education, and so on and so forth. I do a lot for free on a sliding scale basis. You make that possible when you buy the books that I write. Plus, help me pay bills. And I'm thankful for my wife as we walk through this journey of life, because we've been through a lot. We adopted 2 special needs teenagers. They're now adults, and we moved to Kentucky. We're now here November. We're here a year, and we're grateful for this opportunity as we just build a new portion of our life here, semi-retired, trying to work and whatnot. So getting into today's topic for the video, is a medical director asked me, what's the best way to find out where a patient's at in their journey? How do we know when they're eligible for a hospice? How do we know in terms of recertification? Please bear with me. I got out 3 books, but I forgot the 4th. My bookshelf was right. It's a very small room. So I do want to give you the answer, but it's going to be basically dealing, this is going to be the predominant one. God willing, I've already been invited. They're already advertising that I'm on the ticket. One of three keynote speakers, the first hospice nurse keynote speaker at the South Carolina Hospice and Palliative Care Conference in South Carolina, March 27, 2026. So I'm great. That's another gratitude point. But it's going to be based on this book, the foundations that are mentioned in this book. But also there's this too as well, Mastering Dementia Admissions. We have a conundrum, by the way. Medicare likes to give us a paradox, so to speak. The longer somebody's that has dementias on hospice, the more money Medicare and our country's saving, but don't you dare admit them too early. Oh my word. So this book goes over how do you know the proper time to admit a loved one with dementia, that they're going to get the full benefit and be on as long as possible. This, by the way, while not related, this is part of the holistic series. This goes into how to stage any type of dementia. And then I mentioned about keeping people on that should be on master and hospice recertifications. So in brief, I brought up those books and I'm going to put the links in the description below. But the key part for my fellow hospice nurses, if you buy these books, I thank you. But that's not, I brought them out because maybe you might be interested, but I want to go over here. But I'm not going to just say buy the book and buy. Let me go over what's so critical. What is so critical? When you do an admission, if you see, whenever you see the patient, it's just a brand new patient for you. Somebody else did the admission. Maybe somebody else did the post-admission visit, but they're now your patient. Maybe this is and I'm going to give some fine print because I've been there where it's like, I have 8 patients today, and what are you asking me else to do? What else are you asking me to do? I've been there. So if it's a PRN visit and you're dealing with a crisis, you may not be able to do this. Work through the crisis. That's more important, by the way. The human interaction, the human condition is more important than check boxes. I want to put that out there first and foremost. But if you have the time to do what I'm going to be talking about, please do it. Your admission visit, even if somebody admitted them and you're seeing them for the first time on the post-admission visit, do what I'm about to share with you. They've been handed to you. You're now the new case manager for this patient. Or maybe you're subbing, your coworker, they're on vacation or they're out sick, and you're seeing the patient for the first time and it's not a PRN crisis. Let me just give that disclaimer, because again, you already have your hands full. But if you're able to do this, and I apologize for, I'm noticing my camera is having some issues with light flickering. I don't have a professional light set up yet. I don't know when. But so I do apologize for the light going in and out in the camera. That's one of the faults for the Panasonic the lens kit that comes. I think it's a 12 to 25. I don't have the numbers memorized. But what I would like you to do is with the patient, if they're cognitively able, and you'll be able to get that really quick with your introductions and questions and answers. Anybody who's been a nurse for a few years should be able to, and I know I'm being a little bit judgmental with this statement, but you should be able to have a handle on, is this person going to be a good historian? For those of you watching, what's a good historian? I want to define some of my terms. So in the medical field, when we say somebody's a good historian, we know that we can relatively trust what they're saying. It's not there. You've probably I think everybody who's an adult in their life has met at least one person in their walk-in life. Man, they're good at making up stories. I don't know what to trust or not trust. They're good at making stuff up. So anyone who has dementia, no matter where they are on the FAST scale, they could be stage 1. If they have dementia, they're not trustworthy. I'm not saying don't trust them. This is 2 parts. I'm not saying, oh, like I'm weird. Okay, I'll take a cup of coffee or, or whatever. depending on the situation. I'm not talking about trust them to give you a cup of coffee versus motor oil. But if you're going to be asking questions, it's going to be part of the documentation to determine if they're eligible for hospice or recertification. You want to make sure that it's a good historian. So if they're cognitively could participate, you want them as part of this discussion that we're talking about, this interview. You want the primary caregiver there, even if they are trustworthy. Now, there are fine print areas. I wish we lived in a world of no fine print. If you're ever interviewing somebody for suspected abuse, where you might be involving APS, Adult Protective Services, CPS, Child Protective Services, you want that person alone. If you're ever questioning where they're at on certain scales, like the FAST scale, it might be better to interview them alone. But in the general sense, for what I'm talking about, if it's safe for, you want the primary caregiver there too. And I like to have them lined up in a way. I'm not, I'm typically at their level. So if they're standing, I'm standing. If the person's on the bed, I'm pulling up a chair. I'm at a standing desk right now, in case you see me duck. But I'm getting at their level. And I like positioning myself from a body position wise, where I could see the person I'm talking to, typically if we're talking to patient, but I want the primary caregiver, if they're able to be in the room where I can see both. And if a family member who visits often maybe, or is part of the care team, I want them there too. And I'm trying to position myself where I can watch everybody. This is critical because a lot of our communication is by body language, not by what we say. So the majority of the communication that's ever communicated is our body language. After body language, the next is tone of voice, inflection, volume, those components. The last part is the words that we speak. So by being able to see everybody, and this is a case where I strongly encourage you to use Notepad. I know we're in the age where people have their laptops and their tablets. I don't have my clipboard handy as I'm looking over at my bookshelf, but I'd have my folding clipboard and I'd have it out and I'd have paper and I'd be using pen and paper. And what will counterphrase, how this proceeds is, because I'm taking this from the standpoint that I've not seen them. If this is a recertification visit, obviously, if I'm doing my own recert of my own patient, I have. But if I have not seen them, I'm going to be going, I'll do the introduction. If this is the admission visit, I'll identify myself. I'm Peter. I'm a hospice registered nurse. Now, I wish we lived, I mentioned this before, I wish we lived in a world of no fine print. If I was told in advance, and I don't like this, I don't agree with this, but I also don't buck the chain of command in certain areas. If I was told don't mention hospice, I won't mention hospice. Where I said in certain areas, I've told my manager, I've told family members, I will say, I don't mind coming in and saying I'm a visiting nurse because that's still the truth. I am a hospice visiting nurse, so by leaving off the word hospice, I am not lying. I know there are parties, and that's its own conversation for another day, lies by omission. There are times that's 100% correct. I believe there are times where it's not black and white. I'm not talking about fibbing. I'm not talking about, I don't believe in white lies. It's either truth or lie. But I will tell them, I can say I'm a visiting nurse, but if they ask me, because my uniform typically has Peter, Grain Hospice, Sierra Care Hospice, Lifesong Hospice, and Palliative Care, and so on and so forth, it has that on it. My bag will have that on it. I've had coats that has that on it. I'm not hiding that. If they ask, what's that? Guess what? The beans are coming out because I'm not a liar. I am not going to lie. I'll distract once, but after that, it's 100% direct truth. And those of you who watched the channel, my very opening video, when I was asked by a family member who had a very young, healthy, otherwise family member, how did he get this extremely rare cancer? I shared what Dr. Patrick Gilhole, a medical director for Grain Hospice, shared with our entire team. I shared. Was that what caused me to get fired because I told them the truth? I may never know. May never know. But so I share that with them. But part of the question I'll ask, if I'm not told in advance, don't bring up hospice, I will ask, what does hospice mean to you? That will be the very first question I ask. What does hospice mean to you? I'll hear them out. I will not interrupt them, even if it's way off base. I will hear them out. I'll take key memory notes. I'm not writing word for word. I'm taking notes that will trigger my memory, my recollection. If they got anything wrong after they are completely done thinking, because keep in mind, active listening and use these. When they are done, I'll say thank you. And I'll ask, I appreciate that you shared. I'll reflect back. This is what I heard you say, my understanding thereof. And if they got anything wrong, do you mind if I make some tweaks? I like using the word tweak. That's a Peter thing. Tweak or otherwise make some additions or corrections. Most of the time they said yes. I've not had anyone ever say no, but there's always a first out there. And then I'll do my correctives. Then I'll ask, what brought you to hospice? That's going to give you a lot of information. And just so you know, if you're doing the post-admission, maybe this is the third or fourth or the sixth visit. I've had cases where I came in literally in the middle. It was like a week or two before the recert. And I'm told, you're the brand new case manager. Well, we told that the previous nurse this, and I'd fall into sort, I would go, I don't mean to waste your time at all. I would share, I'm taking, I've been asked to take over the case. I'm now going to be the case manager. You, your loved one matter a lot to me. And I've read the notes, and that's what they put in. I want to hear this from you because you matter, and I'm going to be doing my best to do my best for you and your family. And in order to do that, that's why I'm asking you these questions. Not to take up your time, not to make this a longer visit than normal, but I want to learn so that I can provide the best recommendations, best advice. I want to be invested in this, and this is how I get invested. And typically they're okay with that. What brought you to hospice? And they'll give me that story. And again, and listen. And again, I'm taking notes. And sometimes they'll answer some of the questions I'm going to be asking now or next, and I won't necessarily ask them. But a lot of times they circle the garden, so to speak. They circle the property versus going deep in. So then I'll start asking before, and this is before you got on the hospice. Before you got on the hospice. Now I do, again, back to the fine print. The case that I had where it was brought in 2 weeks before recert, I do want to let you know that before I went to this question, I was asking, and even before the first couple questions, I'm brand new to this, not brand new to hospice, I'm brand new to your case. Can you tell me what your last 2 or 3 weeks were like with the previous team member or nurse, however the case was structured? And I'll get that information out because I don't want to miss that. I want any concerns, any symptoms out of control. I don't skip the standard part that's extremely critical if I'm coming in midstream. That still needs to be handled no matter what. I need to address that. I need to look at medication refills, any ongoing symptom issues, any reactions to medications, any med reconciliation needs to be done, and so on and so forth. That is extremely critical. But then I'm going to be going over, before you started hospice, what were the 2 weeks before like? Depending on how they answer, I'm looking at functional decline, moderate to severe functional decline. When we talk about March of 2026, my entire presentation, I shouldn't say my entire, the bulk of it is going to be based on this book. I love the interviewing. My Professor O'Neill from Harrisburg Area Community College at Lancaster campus, I don't know if she's still instructing today, but she taught the health and assessment class in clinicals and really brought out how important it was to get that health assessment. And a lot of times, like I went to cardiology, Harrisburg Hospital after that, and you kind of miss getting into that because, you know, you're not the person admitted. You might be admitting them to the floor, but the previous floor did all the admission questions. So you're just doing check boxes. This is digging in. What were the 2 weeks like? And we'll get over what functional loss is in a few moments. The last 2 weeks before you came on the hospice, the last 4, the last 3 months, and the last 6. And on my pen and paper, and I'm doing approximations, putting in approximate dates and approximate times. When I say time, I'm not saying necessarily 8 o'clock in the morning, unless they say 8 or 10 or in the afternoon. But I'm looking at when did they actually start hospice, and then I know how to backtrack, do days math going backwards. And so what you're doing is like, how fast are these changes occurring in relation to one another? And what I'm looking at is moderate to severe functional decline. What is the functional decline looking at? We're going to be soon on the landing zone for this video. We're soon going to be on the landing zone for this video. So functional decline. Currently right now, as you're watching this, I'm on room air. You don't see any nasal cannula, no mask or anything else. I'm on room air. If all of a sudden, listen to the words I'm using. If all of a sudden, acute, if all of a sudden I need to wear oxygen, whether it be 1 liter, 2, whatever the liter flow is, 24/7, that is a significant change of condition. If all of a sudden, again, those words, acute, all of a sudden, I now have to wear oxygen at bedtime, but only at bedtime, now we're moderate. Now, some of these descriptions, for some people, that might be what tomato, oxygen at night might be considered severe. But the key here is what we're looking for is moderate and severe, moderate to severe changes. So whether I would call it moderate and another person calls it severe, we're still counting them. We're not excluding them. What we're looking for is a map, a velocity map of downward changes, how fast things are coming down. And what that does is it tells me approximately how much longer they have to live. And when I say it, I am not God, I will never be God. There is only one God, Christ Jesus, God the Father, Son, and Holy Spirit. And I'm not trying to preach at or to you, I'm just sharing my faith. I am not God, nor am I a prophet. But over the years, I've come to the conclusion that if we can map out on a calendar how close these moderate to severe declines are to one another, we could approximate how much longer they have until they die. And when I say until they die, I don't mean drop dead on the floor. I mean start the active dying process. Those of you watching, there's 2 stages to dying, the transitioning phase and the dying phase, the active dying phase. I'm talking about the time to active death, actively dying. I believe that's the best way. There's a lot of scales. This book goes over a lot of scales, especially in the back. This is an area also, and I'll be bringing this up in March, or at least I hope to. My memory being the same as it is today, if it is that way in March. I've been trying to memorize my entire presentation, even though I'm going to be up there with whatever clicker tool that they have. I'll bring my, I have no idea how, I have to check with Dr. Ben as to what that's going to look like. But Europe has a huge leap on us when it comes to scales for palliative and hospice care that we should be adopting, because I believe that our goal is anyone who is eligible for hospice, we need to admit them. And if they remain eligible, we need to recertify them. And that's part of why I write the number of books that I write. They're highly focused on very specific topics. You know, hospice, this is a broad-based book. I wrote this because dementia is a whole different category. It's covered in here, but I wrote this because I wanted to give more guidance, more power to have loved ones with dementia get admitted and kept on board. I wrote this from the holistic perspective because not everybody qualifies for hospice, but how do you know where they're at in order for whether it be the PACE program or other programs out there? And back to the recertification. So I do appreciate your time, but sorry about that. My Lumix was running on battery power and the battery ran out. I do appreciate your time. Thank you. Take care and God bless.